Do you want to make your own podcast? Spotify has a platform that lets you make one super easily, then distribute it everywhere and even earn money all in one place for free. It's called Spotify for Podcasters. And this is the platform that I use because it makes it so simple to record and distribute your podcast all in one place using your cell phone. What you need to do is download the Spotify for Podcasters app or go to www.spotify.com/podcasters to get started. Hello, my name is Catherine Moore, social worker, mom, coffee lover, and founder of Social Workers Rise, where we inspire social workers to connect, expand their knowledge, and change more lives than they ever thought possible. I'm so excited you found my podcast. We will talk everything social work on every level from micro to macro. We will hear the stories of social workers who are doing big things, learn new skills, and most importantly, give you actionable steps to make a difference today. Let's go. Hey, Leslie, good morning.
Good morning.
Thank you so much for joining me on Social Workers Rise. So, again, this is Leslie Rodriguez, and she is just so amazing. She's just so sweet, but yet at the same time, very assertive. And I've seen that you can definitely put on your social worker hat, and I really admire that about you, Leslie. So, thank you so much for being here.
Oh, thank you so much for having
So
me.
I'm just kind of curious. I would love to hear your story about why you got into social work, or, how did you know that social work is what you wanted to do?
Yes. So, let's see. Well, my journey in and of itself could be a whole podcast, but I guess I can give you the Cliff Notes version of it. So, my family and I immigrated to the United States from Mexico when I was 3 years old, and I basically grew up with that whole fear of being an immigrant, until I became like a legal resident. And then I'm also a parentified child, as a result of my parents divorcing. I was 14 years old, and my brother was 5 years old when my parents divorced. So that's when the role of being parentified started. And then basically my brother struggled all of his life because of the divorce. He was 5, so going into his adolescent years he battled a lot with addiction and depression. So my whole life I knew I wanted to grow up and help kids just like my brother, almost like a journey for me to learn ways to help him and understand what he was going through. So I guess it's safe to say that I'm in this field because of him. During my undergrad, I developed an interest in working with children and families affected by autism. And that's where I started behavioral therapy at the UCI Development Center. So when choosing a master's degree, I was really stuck between going into marriage and family therapy, or master's in ABA, or master's in social work. So I went grad school shopping, and I went to as many presentations for master's programs as I could. And it was actually at UCLA that I realized that social work entailed everything that I wanted to do in my life. And it was specifically at USC where I found my heart and my home. So something about the Trojan family and just the vibe I got from everyone there was so welcoming and supportive that I knew like I have to be here. And so I applied to like 4 different social work programs, including USC, and luckily I was accepted. So I went to USC School of Social Work.
Wow, that's
So
and I love how your whole life has almost been just preparing you in a way for your work now in social work, because you did, because I feel like you're kind of my go-to person for like anything related to children and youth, but you've had so much experience just in the social worker field in general. Can you talk about a little bit about what kind of social work you've actually done?
Yeah, so luckily I did have a wide range of social work experience, during my master's and, after. So, I interned at a school, in my master's degree. I was doing school-based social work, and I loved working with the kiddos, but I didn't really like the red tape and the bureaucracy of it all. Anybody that works in school social work knows exactly what I'm talking about. And then after that, I interned at a children's mental health clinic, and I loved it. I completely fell in love with it. I was doing trauma focused therapy. I was doing cognitive behavioral therapy and parent child interaction therapy. And so when I graduated, I really wanted to continue to pursue that path, working with children and trauma and families. And I applied to several children's clinics actually. And one company mentioned that they were in need of a Spanish speaking therapist at one of their adult clinics and asked if they can forward my resume to that clinic. Long story short, I went to the interview. I made sure that I was very transparent about I had never worked with adults. And so I was offered an interview, which ultimately resulted in me accepting my first role working with adults. Um, and so that was my first job out of grad school. I worked at an adult mental health clinic in Orange County for 3 years, where I worked with a persistently mentally ill patient. So working with the chronic mentally ill was something that surprisingly became very, very natural to me. There I learned things that no master's degree could possibly prepare you for. I mean, I'm sure even there's things that school cannot prepare you for the things that you're going to learn in the field. And
Sure.
so anyone that has worked for a county contracted program knows the uphill battle, from learning to document, for Medi-Cal billing and learning the lingo and not having adequate training really, because we weren't in school. We didn't really learn like, oh, how are you supposed to write documentation and things like that. I mean, at least at USC we didn't. It was really focused on therapy and all of your interventions. So that was something that I had to learn and kind of maneuver on my own. So it's kind of like a sink or swim, if you will, and boy did I sink before I
Oh
was
man.
able to stay afloat. So in that program, I did a lot of trauma therapy, dialectical behavioral therapy, and I was 5150 certified, which means that I was certified to put patients on an involuntary hold. So
Wow.
it was pretty intense clinic, and with the psychiatrist. And we have a case managers. So the turnaround rate at that clinic was extremely high, like beyond high. And it was funny thing was that something that I was lied about during my interview, because I did ask. I remember that being one of my questions. I asked, what's the turnaround rate? And, the person that interviewed me said, oh, it's low. We have people here that have been here for many years, but they were people in billing. It wasn't
Oh,
therapists. And I even asked how severe and how much crisis work I would be given. Specifically because I had never worked with adults. So I wanted to know, how severe the patients were in the population that I was going to be working with. The program director told me that our patients were all Morse 5 and above, if anybody knows the Morse system, and that it was a recovery clinic, meaning it was minimal crisis response. And of course, later it turned out not to be true. Most of my patients
no.
were at a Morse 3 and 4, and I did crisis response and crisis assessment on a daily basis.
Oh my
So,
gosh.
yeah, let's just say that let's just say that I'm very comfortable in crisis and very comfortable talking about suicide and homicide ideation.
Oh, that is so crazy. And those interview questions are very what it like intuitive. Is that the word? Like
Mm-hmm.
very good interview questions to be asking. And I don't know if a lot of people would even think to ask those questions.
Yeah,
Yeah.
and one thing I did learn about USC was just that intuition. There's certain things that therapists can't be taught. And so I knew specifically, knowing that not working with adults, I had to be very transparent. If they're going to hire me to do therapy with any individual, I should be very transparent in terms of what I feel comfortable with, what's within my scope of practice, and, just evidence based. That's something that was drilled in me from USC, and I thank USC for that. But, because of the turnaround in the clinic, I gradually ended up having inheriting all of these really severe patients, because obviously when a therapist leaves, or clinicians leave, the people that have to be have immediate care available to them is the severe. And so with the turnaround rate, I ended up inheriting all of them at one
Oh
point.
my gosh.
Yeah. And when I mean turnaround, I mean in all positions, including clinical supervisors and program directors. So, at one point I went almost 8 months without any supervision whatsoever. I really I even had to advocate for myself to receive supervision outside of the clinic in another program, you know, um, working with high risk patients. And, I'm talking about suicide and homicide and all these things. I felt it was a point where I felt uncomfortable. I said, am I even doing this right? Like, you
Mhm.
start questioning, you know, um, am I even in the right field? Am I doing this right? Am I causing more harm than good? And, those are all valid questions for, social workers to have. And having, adequate supervision, that's something that's so important, just based on ethics alone. And so I remember having to advocate for myself to receive that outside supervision. And, it was a little bit of an uphill battle, but I got it, because I really said, this is very serious, the things that, could happen if I do something wrong, if I'm doing trauma work. And I even for myself, I stopped doing TFCBT because I didn't feel comfortable, because I didn't have any guidance. Like, I'm out of grad school. Like, I don't know if I'm doing it right. I need someone that's trained in TFCBT to let me know, what? No, that's actually detrimental, or don't do this. And so
What
uh
what
huh.
is TSCBD? What what is it?
TFCBT is trauma focused cognitive behavioral therapy. So that's specifically, again, I worked with very severe patients. So you have like complex trauma. And so that's a very specific, very strategic way of the therapeutic approach is very it's in stages. And so there are certain things that you have to do, and of course there's certain things that you can't do, because you're kind of going back to the trauma. You're having patients revisit the trauma, and you're helping them get through it. And so if I do something wrong, that it could be very it could be very bad.
Mhm.
And so I didn't, having someone revisit these traumatic experiences from their childhood or whatever, not having adequate, not feeling comfortable myself, I could do a lot of harm to a patient if I don't know how to treat that trauma, and be able to provide them with the coping skills necessary for them to, overcome it. And so it was very scary for me. And I said, you know what, for myself, my ethics first, and I'm going to stop doing specific, um, like I said, it's very structured. So I said, I'm going to stop doing this because I'm not comfortable. I don't have anybody to tell me, actually, you shouldn't be doing that. You should do this. And so, yeah, so I did that for myself. And so I think at one point, like I said, I had 65 therapy patients, and because productivity was never an issue for me, whoever was in charge at the time really never checked in on me. In county contracted clinics, it's all about your numbers. Are you meeting productivity? Are you meeting your dish, your numbers? And as long as you're doing that, that's at least my experience, that's really all they cared about. They never, whenever I was given supervision, quote unquote, it was more so talking about my productivity. It was talking about the numbers. It was talking about the program expectations. It was never a time for them to check in on me like, hey, any transference, any counter transference, what's going on. It was never that. And that's what supervision should have been. And that is ultimately what I ended up advocating for myself, outside of the clinic. So, I stayed in that clinic because of my patients. Having to change therapists and psychiatrists so frequently was heartbreaking for me to see them. They would relapse, they would have these episodes of, abandonment. And it was hard. It was really hard. And I didn't want to leave them. I didn't want to be one of those people that abandoned them and according to their eyes, and I wanted to be their safe person, their consistency in their life through their recovery. And then, it sounds it sounds very familiar. It wasn't after I left the clinic that I realized, wow, this sounds like, you can go back and many therapists can say, I'm doing to my patients what I did to my brother. I wanted to be that safe person. I wanted to be that consistency and that safe, giving them that safe space. And it wasn't after the fact that I realized that that's what was happening.
Yeah, well, you had such a strong emotional tie to your work that it wasn't just a job for you. You weren't there just to meet the productivity numbers. I mean, it was your life's mission to
Mm-hmm.
help people, and it was personal for you. And I really, respect that about you. And I just can't help but think, all of these, daily crisis mode, like that is just so much to even handle and cope with. And I know that we talked a little bit about, your experience with vicarious trauma, and like once you were out of that situation, that you kind of realized. So, can you talk to us a little bit about like what is vicarious trauma, and what did that look like for you?
Yeah. So, like I said, the vicarious trauma, I didn't realize it until after I left the clinic that I realized what was happening. I think it was because of my symptoms, and it was some bizarre things too. Like I started having nightmares, like very specific nightmares about specific patients, like actually completing suicide and things like that, where I realized like I felt very guilty of leaving them. And I felt that if something were to happen to them, I felt that it was going to be my responsibility. And so, of course, like while I was at the clinic, I had different things happen, but ultimately I didn't realize how severe it was until after I was taken out of that environment. So once I was in a better headspace and in a better environment is when my body started processing all of the trauma that I had experienced in the last 3 years, which was very wow. Like it was like, a slap in the face. It was like I talked about trauma and all these symptoms with my patients on a day in and day out. And it happening to me was very like eye opening. It was like an out of body experience, really. And so I want to go talk about a little bit more about that. But social workers in the field and even providers, there's four potential effects that can happen at work. So there's four things. So it's one is burnout, two is moral injury, three is secondary traumatic stress, and four is vicarious trauma. The reason that once I left that clinic, it then became my responsibility as a clinician to learn and research burnout and all of these things, because I needed to be able to take control of my transference and counter transference and heal. Really, it was just a healing process for me. And so I said, I really need to inform myself and really learn about what I just went through in the last 3 years so that I can be a good clinician. So I started researching, I started going to conferences, and I started taking trainings on these 4 specific uh, components, in the workforce for social workers. And so that's where I learned the 4 differences. So basically, burnout, I hope a lot of social workers will probably relate. And so burnout is basically just the exhaustion, physical emotion, and psychological emotion of being having large caseload and like chronic and complex cases. So burnout was something that I knew off the bat. While I was in the clinic, like, I'm burned out. Like, I am tired. I'm feeling I'm feeling drained. I feel like I don't want to do anything after I get out of work. And, a lot of times I stayed over the time that I was supposed to. So it wasn't like an 8 to 5. There's sometimes I would go home at 8 or 9. And it was just, burnout was very apparent to me. It was like I knew this is exactly what was happening. And it was because, having 65 chronic, severe therapy patients will do that to you. So that was
Mhm.
burnout.
So you knew,
Moral.
so
Uh-huh.
you knew like in the moment or, while you were still in that environment that you were burnt out at that moment?
Yes, so I did know at that moment because I had learned about burnout in grad school. So I remember it was maybe like one class lecture on it, but I remember it. I remember I had little flashbacks of being in class and hearing about this and knowing about this. And so I said, okay, because they always said, don't burn out, don't burn
I
out. And so I knew exactly what was happening. I knew I was burning out. So I knew that for myself. And so I knew that I needed to manage my workload. I knew I needed to adapt different time management skills to keep my sanity, because that's why a lot of the clinicians left, because they were burnt out and they couldn't manage. Like, even though we were all seeing patients like back to back to back, we would get behind on documentation. We would be um, almost drowning in documentation because we just couldn't keep up. And so I adapted throughout the years. I adapted a system for myself that worked for me. And so that was something that I did to kind of help take control of that burnout. I mean, it was going to happen. It was inevitable. 65 plus patients, like, there's just no way, but you have to have some sense of control. So that was one thing that I did for myself.
Yeah.
The other thing, mhm.
What was your system? I'm kind of curious to hear what system.
Yeah, so a lot of the times, like in the very beginning, I would see all my patients, and then at the end of the day I would do my documentation, and that's when I ended up coming home like at 8 or 9. And so I realized, like, I did that for a couple months, and I said, no, this isn't very effective. Like, yes, I'm getting my documentation done, but it's just not working out for me, for my personal life.
Mhm.
And then I started incorporating the doing the note while the patient was there. So I would have therapy, I would do, and it kind of helped outline how my session would go, and talking about um, what I was going to talk about, what we talked about, and what we were going to touch base on the next time I saw them. So I kind of started doing my notes like with the patient. And as soon as they left, I would kind of try to finish it before my next patient. That way, it also gave me a little bit of space in between to process what we just went through, or whatever the case might be. So that ultimately ended up being the most effective for me. And then I ended up coming home, in an appropriate time.
Yeah. Did you find that doing the notes during the visit, did it impact your interaction or the quality of visits at all?
I didn't do it with every single one of my patients. I knew which ones. So I had a lot of patients that love to talk. So that helped kind of really set firm boundaries and kind of redirect them, if anything. So that helped those specific patients. Like, this is the plan for today. We're going to focus on this instead of going off on different tangents. Like,
Mm.
it really just helped structure the session. But of course, like when I was in crisis response, like I wouldn't do that. I would just document that I completed like a crisis assessment, and these are the interventions that I did. We did a safety plan, et cetera, et cetera. So I really gauged. Some of them just, of course, they wouldn't be open to it, like, more of the paranoid patients, like, what are you writing? I want to see what you're writing, and what are you saying? And I just knew that wouldn't work for them. So it's really that clinical judgment.
Okay, that makes sense.
Yeah. Then another thing I experienced was moral injury. That one is specifically that inner conflict. This is and a good example I have of this was when one time I had one of my program directors at the time and supervisors, because they would check all of our notes and then just say, oh, add another intervention or whatever the case might be. And so I remember one time they asked me to change my note, and it was specifically a note relating to a child abuse. So I had to write a CPS report. And so they said, oh, change your note. And I said, I'm not comfortable changing my note, because I wrote down verbatim what the patient had told me, and this and this. And so I gave really detailed examples. And so I remember them telling me, I'll never forget, they said, Medi-Cal doesn't care about what the patient said or the interaction. Your notes are like a receipt of services. They don't care about the context. So just eliminate it. Just say that you talked to the patient and that you completed a CPS report, and that's it. And I said, no. It was that conflict where they were asking me to do something I didn't feel morally correct. Right. And I said, I'm not comfortable, and I feel very uncomfortable what you're asking me to do, because if something were to happen, I need to cover myself that I did the proper, steps. I did, everything. I asked the right questions, and I'm covering myself. And it was hard, and of course, because of that, there was some, how would you say, I was reprimanded and things like that. It wasn't like direct, but their whole vibe changed with me, that I was defiant or whatever the case might be. But that was a good example of that moral injury. Like, and it didn't happen just once. It happened several times where they ask you to do something that you just know doesn't align with your ethics. And so that's something that I know, like, from several social workers in that clinic and, in the field, that they felt at one point in their career that that happened.
Yeah, I didn't know that there was an actual name for
it. Yeah, it's an actual term.
Okay. Awesome.
Yeah. And so then the third thing is called secondary traumatic stress. And that is basically really in line with symptoms of PTSD. So, of course, trauma exposure is required for that. And so exposure to suffering, and especially like imagery and things like that, and just context of the day-to-day interactions you have with your patients, so that ultimately leads to these symptoms of, that really go along with PTSD, the nightmares, the triggers, the emotional response to certain stimuli. And so that was one of the things that I remember experiencing after leaving that clinic, was that I started having these nightmares. I started having flashbacks of certain sessions, of certain involuntary holds that I made, certain situations, and mentioning certain things I remember would trigger like an emotional response to me. And it was just really, really out of body experience and dissociation, almost like, what is happening right now? Like, I can't identify anything that made me feel this way. And then just really doing deeper work, I realized, wow, like, this reminded me of this person, or etc., or a patient in the past. And so that's secondary traumatic stress.
Oh.
And then lastly,
I think, so if I understand correctly, I think I have a story of when I experienced secondary traumatic stress within hospice. So I had a patient at a certain board and care facility, and I would see her, like, she was generally, well, you know, well cared for at the facility, as far as I want to believe. And the caregivers only spoke Spanish, and I don't
mm-hmm.
speak Spanish, but they spoke like basic English, and I spoke basic Spanish. So whenever I went, I saw this particular woman, and I said, she looks like she's in pain and she has dementia, and so, I know that she's not trying to manipulate me. um but they said, oh, no, 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 she just looks like that, that's just her face, or we just gave her pain medication, we're just waiting for it to kick in, and we did it right before you got here. Or it would be like, oh, well, we're going to give her the pain medication, she's due, in 30 minutes for the medication. But and so this went, like, there was a different response every single time I went, like, she just was like that, or we just changed her, we just had to move her. And like for months this poor woman was in pain, and I talked with the nurses and the doctor who saw, and they're like, yeah, everything is good. And so I'm like, okay, maybe they're telling me the truth, and all of these things just so happened to line up. And so she ended up passing, and a couple months later, maybe even a year later, I'm not sure, there was another patient, another woman who was in that exact same room, the exact same position in the bed, and
Mm-hmm.
in pain again. And I was like, no, there's no way. Like, there's no way that she is just looking like this. There's no way she's being manipulative. There's no way that, like, we must do something to make sure that she's not in pain. And it was a much stronger response from me. And my supervisor, she would see me in the IDT. She's like, Catherine, what is going on with you? Like, why are you so, you just seem extra passionate about this particular person. Like, what is it? And I said, and I explained it to her. I was like, well, this is the second time I've seen this in this home, in that bed, in that spot. And I just kept getting flashbacks in my mind to the first woman. Like, honestly, I don't even remember the second person. It was just like the first woman, like her face and her pain is kind of ingrained in my memory. And I
Mm-hmm.
like continued to hold on to that. I need to let go, but it's just like, and I think it almost serves me to know, like, when my intuition is there, maybe see if there is more that we can do. um and just, it ended up that because I was so adamant about the second person, that the team and the medical team did take it a little bit more seriously. And it came out that the nurse that was going, that, like, i don't know I don't know if she just didn't want to, like, make the facility mad or make them I'm not sure. But
Mm-hmm.
I definitely saw a difference with the second person, and she wasn't in pain, for like as long, so it wasn't as bad of an experience. So is that kind of like
Yeah.
secondary traumatic?
Yeah, because you have these flashbacks, it starts affecting your response, your emotions, and your judgment based on this one experience that happened. And so it's a very real thing for social workers. You'll go back to, and I mean, I have endless stories of this because I went through so many, I mean, 65, at one point.
Mhm.
But it all kind of started, I guess you could say, eventually, some of the stories of my patients started kind of meshing together, where it was just like all of my rape survivors, and all of this. And so that's going into this vicarious trauma, the last component of it, where, the trauma exposure is required. And it's this change in like worldview and like breakdown of like belief system. So then it starts impacting your like interpersonal skills where it affected my relationship. It affected my relationship with friends and, all of these things where, I had friends that would reach out to me and would want to talk about their stress and what's going on in their relationships. And it was a point where like, oh my God, I cannot listen to um, another sad story today. Or let's say if my personal friends were having issues with, depression or suicide thoughts, it was like, oh my gosh, like here we go again. It really starts impacting you. And so I was always still there, but I remember thinking to myself, like, oh, your story's not as bad as my patient that went through da 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 da. So it really starts impacting you in a negative way. And so I didn't know that that's what was happening until I was taken out of that environment and really doing the research and the work of what was going on, that I realized that, oh wow, this is a real thing, and this is something I went through, and this is what I'm still going through, because there's still, even to this day, watching certain documentaries or watching certain things that I will cry. And I mean, that's a normal response to cry, but for me it was a little bit like a sob. And I remember having these flashbacks and feeling this connection to certain things that are a little bit out of the ordinary. And it was because of everything that I had endured in the past 3 years. And not just that, but just in my life in general, like wanting to be the savior for all these people, and going in kind of what I went through with my brother, and wanting to help him. And, you know, it's just taking on that role, that parentified role for every person that I came in contact with. Like it was inevitable for me to burn out and just not be able to cope.
Mhm.
you know
Yeah, because there's just no way that you can save everybody, and that's not even your role, really. I mean, I don't know if I kind of see your role as, or people in that position, as being a guide, as a helper, as a support system to, and a teacher to help people learn how to cope with these skills, but not necessarily to save them. Does that make sense? Okay.
yes. Oh yeah. And I didn't realize that until after the fact. I realized that I still had a lot of work to do in terms of my own issues with, my childhood and everything that I had gone through in life. And so being able to be a better clinician for it, and so it really took a lot of time to be able to have that self-awareness. And I mean, as much as it was difficult what I went through, I think that, I mean, I wouldn't, maybe I would have changed it in terms of advocating for supervision a little bit more, but ultimately I learned all the skills that I have, and I learned everything that I do have now is because of that situation. Similar to my childhood. People say, oh, do you wish that you would have said something to your parents earlier, or things would have been different in your childhood? Like, I mean, I wouldn't wish any of the pain that I went through as a kid to anybody, but I am the person I am today because of it. And I think that I'm the clinician I am today because of everything that I went through in that clinic,
Definitely. And it definitely
Mhm.
takes, like, you're actively reframing all of your experiences to not have them as a weakness, but to have them as a strength that you now use and you build on to help other people. And I think that's amazing.
Yeah, a lot of the times I think about, every social worker's asked, like, oh, so what's next? Where do you see yourself in 5 years? Or, and I always thought, I love therapy. I love doing what I do, but I really, something about that experience really, really, I'm drawn to being a supervisor, being a clinical supervisor and helping other social workers in the field because of the experience that I went through, and being able to advocate, for other social workers, and knowing that, being able to teach them of having that awareness of their symptoms, and being able to acknowledge the emotional response, and being able to identify that, how important that is. And so I think that's where I see myself in my next, the next notch would be, hopefully be a supervisor.
Yeah, that's awesome. I think you would be a spectacular supervisor. I think.
Thanks.
I'm kind of wondering, so, you listed the burnout, moral injury, secondary traumatic stress, vicarious trauma, and that you were there for 3 years. So, at what point or how long did it take for you to be in this chronically stressful environment for you to start feeling these different emotions? Was it like immediately? Was it a year? Like, do you remember what the time frame was?
um I started feeling it at the end of my third year. So I guess being there, this is where I started kind of my personal growth, and just really started being more aware of my emotions. And then I started forgiving myself and accepting that if I leave this clinic, it's going to be better for me, and that it wasn't going to be my fault if something happened to my patient. So being able to accept it was really important. And I told them, I gave them so much ahead of time. Like, I told my patients and the program director, like, I'm trying to transition out of the clinic, but I am ethical and I want to give my patients enough time to process me leaving, because I had the chronic, very severe cases and complex trauma. I needed them to be ready, to when it came the time for me to leave. And so I did that for myself. And I think that it was something that was very important to me, to not to kind of like a transitional thing for them. And I wanted them to be able to cope with it appropriately, and not just I'm leaving it or leaving in the next day or whatever. Like, some of them would just give their 2 weeks and leave and not have that termination process with the patients, which is so bad, but a lot of times we don't have that option, depending of where we're working at, we don't. And so when I ultimately left, it wasn't until maybe a month after, where I was in a different headspace, where the other symptoms, where I was having those residual symptoms come up. So it was almost immediate. Like, I left and then it was time for me to heal.
It sounds like you were in a constant state of like adrenaline.
Yes, I
Wow.
was. And it's funny because even now, when I'm faced with a crisis, I go back to it. I can go back into it really quick, which is good. It's a good thing to have for, a clinical skill, but it's also like, oh, I kind of getting off of the being in the adrenaline, that high, the getting off is really scary, because I don't know how it's going to look until it happens. I don't know if I'm going to be triggered from a patient or some memory or something. So that's always really scary. But luckily, I'm able to get into that state of mind really quick. I can almost instinctually.
So I'm just kind of wondering, was there anything that could have been done, or like what did you need in that position? Like, what could have been done to prevent the burnout, or at least to reduce all of these negative emotions, give you a chance to just like decompress and not be chronically stressed and in adrenaline mode? What could have been
Yeah.
done?
Supervision is by far the most important thing. Like, I cannot emphasize that enough. And I don't mean just having supervision is enough. I mean quality supervision is detrimental to the coping and the recovery of the vicarious trauma and everything that social workers face in the field. It's suggested in several studies that, having tangible acts of care, meaning making help, making how would you say it, like having these tangible things that you have as a support system during these times are so important. And so it's really supervision. It's having that support system, and it's not just family and friends, it's like colleagues, it's your coworkers, it's the supervisors. It's having that safe space for you to be able to do that.
So yeah, it takes more than one person, like one supervisor. It definitely takes a team of people to be around us, and quality relationships that don't drain us, ones that lift us up, and we're just kind of rekindling spirit, because we're not meant to live this life alone, and much less we're not made to go through all of these stressful events by ourselves either. Which unfortunately I feel is kind of in our culture as Americans, like, oh, you just deal with it and move on, but that's not that's not always effective or efficient in these extraordinary circumstances.
Yeah, and I mean, just to quote some of the studies on all of these things, one of the biggest things is working in a place that supports you, and making a difference, that you feel that you're making a difference and that you have the support, of your colleagues and supervisors. More specifically, for secondary traumatic stress, it is recommended that individuals seek a mental health intervention, given that you will be treating literally PTSD like symptoms. And that is, obviously best done with a therapist. But other than that, I think just having that support, and that's something that we developed in that clinic. The clinicians and I, um, we we didn't have adequate supervision, so we did it for ourselves, kind of instinctually. So, and not even on purpose, it was just, we would go out for lunch or happy hour, whatever, and we would just kind of process on our own because we didn't have that outlet. And it's just so, so important.
Yeah, definitely. Definitely. So what are some things that social workers can do, if they feel like they may be at risk for some trauma, or experiencing it, or recovering from it?
Yes, I think one of the most important things is acknowledging what's going on and be having that insight of your emotions and thoughts. I believe that one of the most important things is to advocate for yourself. Once you start feeling those emotions coming, or those thoughts, and kind of this response to certain things, I think it's really, really important to have that awareness of your symptoms. I believe knowing what certain emotions and responses are coming from, help identify that residual trauma response to something that happened maybe months ago, weeks ago, or years ago. I think knowing that, clearly, for example, for me, knowing that I clearly hadn't processed something helps me be a stronger person and a clinician moving forward in all the aspects of my life. If I get emotional talking about something, I know that I hadn't healed completely from that experience, and that's okay as long as I address it and acknowledge it. So I think that for clinicians, the most important thing is, first of all, being aware of their emotions and their symptoms, and most importantly is, advocating for themselves, advocating for supervision. And if a supervisor is not doing it for you, then advocating to get outside supervision, or hey, can we have a group started or something? Because I think that is so, so important, because having that support, or being able to say to a supervisor, hey, I don't feel supported, I don't feel validated, and I don't feel that I have this safe space to talk about it, is crucial for, you know, all social workers.
Definitely. Definitely, for sure. Well, that's super powerful, Leslie. Is And thank you so much for sharing your stories, and, for just giving us some insight into all of this. I know I learned a lot and had realizations while we were talking. So thank you.
Yeah, you're very welcome. I'm still very close to some of the clinicians I worked with. We've become very close friends. I was fortunate of meeting them, in my path, and somehow trauma brought us closer
Yeah.
together. And we make time to get together, and we still process things going on in our lives, even though we've all taken different paths in life, because literally everyone that I worked with doesn't work there anymore. And sometimes we tie it to unprocessed emotions of things that happened in that clinic. It's almost like a group supervision, if you will. We go around the table, we check in and talk about what's going on in our lives, and we are there to support each other and validate, and sometimes get reality checks while we're drinking mimosas or wine during brunch.
I love it. Awesome. Was there anything else that we didn't cover that you feel is important?
No, I mean, reach out. I think if any social worker out there needs somebody to listen, or anything, they can always reach out to me, or they can even take initiative and start a group themselves, if they're in a community and just want to open up a forum, or just something like a meetup of like, hey, I'm getting together, I'm a social worker in X field, and I want to get together for happy hour with fellow social workers just to kind of talk and process. Like, do it. And if they're around me, I'll do it
after COVID-19 blows over.
Oh my goodness, yes, which I already anticipate. Our social workers, we have a long road ahead of us, with kind of healing from this. It's affected us personally, and in our communities and our patients that we work with. So, more than ever, I think that social workers should rise and unite with each other, and just be that support, because their social workers, I think, are going to play a very important role in the months and years to come.
Oh yeah.
After this.
Oh yeah, for sure. There's so much already starting, and we're really at the beginning of everything. So, definitely. And I think that this conversation that we're having is very relevant to everybody, because we need to make sure that we are in the best mental space possible, for ourselves and our families and the people that we help and work with. So that's very powerful.
Yes, definitely. I hope that there's a lot of wine Zoom meetings up in in our upcoming futures.
I had a wine Zoom meeting last night.
Oh, nice. I haven't had one yet, and I'm just might reach out to fellow clinicians and people in the field right now, essential workers that would love to have one.
Thursday.
That's right.
That's awesome. So where can people find you?
Let's see. So, I mean, I would say you can find me on Instagram, but because I really prioritize my self-care and boundaries now, you'll just basically see me doing self-care and wine and brunch and mimosa. So maybe that won't be a good reflection of who I am. But for now, you can find me on LinkedIn, Leslie Rodriguez, if you want to reach out to me, any social workers. Leslie Rodriguez, Lesly, Rodriguez with a Z. My picture, I have a flower and red lipstick. I think I'm like, I should be easy
Looking
to find.
so cute and pretty, as you always do.
Thank you.
All right, Leslie. Well, thank you so much for your time. And, I hope that we get to talk again soon.
Yeah, definitely. Thank you so much for having me. And if I can be of any additional resource or anything, give me a call.
Will do. Thank you.
Thank you, Catherine.
Thank you.
Have a nice day.
Thank you so much for listening to another episode of Social Workers Rise. If you loved it, write a review and give us 5 stars wherever you listen to your podcast. This just helps other people just like you find us and join our community. Also, I would love to connect with you on Instagram. You can find me at Social Workers Rise. I can't wait to see you next week. Bye.